Welcome, friends. This is Dr. Jaitly, your cardiologist, on your favorite site, MuniSTHealth, which is a video channel on social platforms, essentially promoting medical education, patient education, in order to improve the clinical outcomes, which I strongly believe is my gut feeling that once you have your patient education to the level of health literacy, as we call it, improved, the patients go back more often to the doctors, comply with their medicines, their prescriptions, their diagnostic tests, have a better chance of understanding what their illness is all about and their treatment options. So as a result, the clinical outcomes definitely improve. And this has been my global initiative, and now I formalized it on MuniSTHealth, as you know. So without any further ado, like I always do in short video vignettes for you guys, mainly I'm going to discuss today, how does nitroglycerin work? Now we know, and nitroglycerin is also called NTG in short forms. Some people like to write GTN, but I think NTG is more conventional. This is because it's basically glyceryl trinitrate also, or nitroglycerine, if you will. So nitroglycerin, that's how we normally write NTG. Now these are sublingual, because they could be used right under the buccal mucosa because they get very easily absorbed. They could be oral, and of course topical, where a cream form comes in, where you can apply a cream or a patch, if you will. And it also comes in an intravenous form as well. So these are the various modes of administration, if you will. But sublingual is very, very common because it saves a lot of angina. Now we'll just talk about the uses first, and then we'll talk about how does nitroglycerin really work. So it's used in angina, since we are on that. So let's do that. It's useful, very useful in angina, all types of angina: chronic stable angina, first time angina, unstable angina, crescendo angina, if you will, or prinzmetal angina, where there is coronary artery spasms. You know that, right? So basically that coronary artery spasm will almost mimic like an acute AMI, as part of a differential, because it has an ST elevation, and that's one of the differentials as a matter for acute MI, and that might be on the boards. So the coronary artery spasm, and if you do use nitroglycerin, immediately the spasms are relieved and the ST elevation goes down. So very important differential, sort of a quick means of knowing right on an EKG. Topical, as I said, of course, and intravenous. Now, intravenous is used also in a setting where somebody's presenting with, say, pulmonary edema. Now, that's where the water collection is, or in a very severe, I call it an acute exacerbation of CHF. And of course, severe hypertension patients, you can apply a patch or give them oral nitrates, and immediately the pressure starts declining. Now, how does it work? Now, let's understand quickly. Now, there are venules, there are capillaries, and there are arterioles in the entire body system. That's what arterial, that's what the circulatory system is. So essentially what's happening is, as the blood is traveling from the arteries, it goes down to the capillaries, and then via the veins, it's returning back to the heart. So as the blood returns back to the heart, now if you have increased capacitance, in other words, the veins, they tend to dilate, or they were to dilate, you will have more capacity, more blood volume sitting right here within the veins, which will be good for the heart. So in congestive heart failure, in pulmonary edema, even in angina or coronary artery disease, or if somebody's having an acute MI, these are all the settings where actually the stretch of the walls of the myocardium will be lessened. Now, the stretch is lessened. Obviously, the heart is saying thank you in a way, because the oxygen required to the demand for oxygen is reduced. So here we have, now this is the balance. On one side you have oxygen demand, and the other side you have oxygen supply. Now, oxygen supply is mainly from the coronaries, we know that. And where are the coronaries? Well, coronaries are sitting right here. We'll draw a quick diagram here for you guys. This is looking at the heart from the outside, and obviously they are rising from the aortic cusps, and the first one just almost travels like that and then divides into two. That's your left circ here. This becomes your left anterior descending artery, and here's your right coronary artery, and then it branches off. Various branches will eventually go and meet with each other, etc. So that forms a little bit of collateralization, and so that's how the heart is totally supplied externally. If you were to look at the heart, this is how the coronaries will look. This is the internal part. In other words, now you're looking at the heart from inside, like looking from the outside of the house and then inside of the house. So anyway, so making a long story short here quickly, you have left circ, LAD, and then you have your RCA. These are your vessels, right? Coronary artery. So obviously in patients where angina is suspected, you have coronary obstructions here. And because you have coronary obstructions, the supply will be lessened. So those patients will have less supply because, you know, oxygen is not getting to the myocardium or to the heart muscle. So because they already have coronaries which are already compromised or they're stenosed, you want to increase the supply or decrease the demand, because that is your goal, right? Because the myocardium has to survive. It has to meet its metabolic needs per unit volume of that myocardium. So how do you achieve that? So either you can decrease the demand or you can increase the supply. Now here is the beauty. The nitroglycerin, it decreases the demand by increasing the venules which have now dilated in the peripheries, like in your legs, in your splanchnic system, in your rest of the body, wherever the veins are, which are supposed to bring the blood back into the heart. Now they have dilated, so the heart is now saying thank you in a way, because it's suffering. It's taking less stress, less stretch. So less stretch on the myocardium. So let's write that. Less stretch on the myocardium. Okay, so this is the myocardium, so there is a less stretch. So that's a good distinguishing feature. Now what happens to the arterial side? The arterial side, the similar way. The arteries will also dilate. Now because it's an arterial dilator, so as a result, when the blood is going up the aorta, for instance, here it was coming via the veins. Now blood is going up in the aorta right here, if you were to look at, and you have arterioles which are dilated. So the peripheral vascular resistance has gone down. So what is the heart again saying? Thank you. You know why? Because now the blood is easily being pumped into the arterial system, which was predominantly all resistance there, and that's what gives us a blood pressure. So in order to have a decent blood pressure, we must have peripheral vascular resistance. Now in patients who are hypertensive, like severely hypertensive, this arteriolar dilatation is very, very helpful, is very, very desirable, because then the blood pressure will decline. And the blood pressure declines, again the heart will say thank you, because then it's easier for the heart to empty out, so the blood can actually empty out. So again, so less stretch on the myocardium and less veno, we'll say veno and arteriolar dilatation, if you will. Okay, so that is the second part. And the third part, don't forget now, the coronaries. What it does is, so basically what it done, these two have decreased the demand for the oxygen, because the heart is saying thank you. Now what it does is the oxygen supply is improved, because we know that the coronaries were already compromised in this setting of angina or acute myocardial infarction, like we just talked about here, or in the coronary artery disease. So because the coronaries were already compromised here with stenosis, say 50, 60, 70% stenosis, at that point what happens is it causes coronary vasodilatation here too. So when it causes coronary vasodilatation, obviously in the coronary arteries, what will happen? The oxygen supply will improve. So now you have an oxygen supply that's improving. You have the demand which is decreasing. What is happening? You have a better milieu for myocardium as well as for the rest of the body. Your blood pressure is declining, your acute exacerbation CHF is getting better, your pulmonary edema is starting to improve, your coronary artery spasms will disappear within a matter of seconds, actually, because it works so fast, especially the sublingual. And the angina, the acute myocardial infarction, if applied early enough, you will see good results. So essentially what you've learned is nitroglycerin really works instantaneously, especially the sublingual variety. The oral takes a little longer time. Obviously, that's meant for more chronic stable angina. Topical works also for more chronic stable angina, sometimes in heart failure we apply it, and even in severely hypertensive patients I've used it. And of course, intravenous nitroglycerin is very instantaneous also, and it is really helpful for severely hypertensive individuals and pulmonary edema patients, and in a setting of acute myocardial infarction. So those are the places where you'd use IV nitroglycerin. Okay, the side effects, just quickly: headache, Well, headache is very, very profoundly world famous headache you get with nitroglycerin, but not everybody gets it. But again, it's livable with a Tylenol. You can use a little paracetamol and it's fine. Dizziness can occur, remember that. And again, lowering of the blood pressure profoundly can occur. So you have to be very, very careful. Monitor the pressures soon after you take the nitroglycerin. Make sure the patient is sitting down or laying down. It's not walking around or standing while you're giving the nitroglycerin. And most importantly, do not use it. Do not use it with sildenafil like drugs or Viagra, if you will, because that's a big no-no. Because if you combine this with sildenafil, nitroglycerin with sildenafil, that's a big no-no. Why? Because it will immediately lower your blood pressure, and even sometimes sudden deaths have been reported, and they cannot be reversed so quickly. And sometimes so again, Viagra-like drugs, if always ask the history. Has the man been taking Viagra for any reasons, for whatsoever, either for pulmonary hypertension or for erectile dysfunction, etc., which is the latter being the more common. And you'll see that nitroglycerin will be contraindicated in that setting, so you cannot use it. So obviously ask history of allergies, history of any severe side effects like you normally do for all medications, but make sure you always ask this history of sildenafil in that patient, or the use of Viagra within the past say 24-36 hours. Okay, well, I thank you again for watching and staying on MuniSTHealth, and stay well and keep spreading the word. And of course, our goal is to improve the clinical outcomes by my deep insight which I have, where I use medical education, patient education, both for medical fraternity as well as for patients at large. Thank you again for associating with MuniSTHealth, and so long, and until next